Hi everybody, I think we'll get started. Just as a first reminder, if those of you who are signing on right now can make sure that your microphones are muted, that would be great. And also a reminder that we will be taking questions at the very end of the presentation. So please wait till then, and we'll go from, looks like west to east for questions today. If you're calling in as an individual, you can chat your questions directly to KT Moderator, who is Gail at St. Mike's, and she will read them out loud on your behalf. So it's my pleasure to introduce Dr. Robin Urquhart. Dr. Urquhart is an assistant professor and knowledge translation scientist in the Department of Surgery, Dalhousie University, with cross appointments with both the Department of Community Health and Epidemiology, as well as medical education. She is also a senior scientist at the BHS Center Cancer Research Institute and affiliate scientist at the Nova Scotia Health Authority. Dr. Urquhart's research expertise lies in health services research and implementation science related to cancer and palliative care. She has built an active research program investigating how new tools, technologies, and practices move into cancer care practice and policy. Dr. Urquhart also holds a graduate degree in exercise sciences and bachelor degrees in both kinesiology and journalism.
Okay, thank you, Andrea. So if anyone has any problems hearing me at all, just sort of, I don't know if you can shout up or just write a note and Gail can let us know. So I'm going to talk to you today about the role of middle managers in the implementation of innovations. It was situated in cancer care, but I'm not going to be honing in on that point as much type thing. Essentially, it's in healthcare. But I will talk a little bit about sort of a study. I will be talking mostly about a study that I've done around this area. There you go. We're back. Okay, sorry about that. So how do I click ahead here? Oh, that's okay. So the learning objectives, which you would have seen on the poster, is to understand the substantive role that middle managers play in implementation processes, to identify factors influencing their commitment to innovation implementation, and to consider potential strategies to optimize their role. So today, I want to start off by sort of giving a few definitions, and that's really just to make sure everyone's on the same page, so you know what I mean when I'm talking about middle managers, implementation, and so on. I'm going to talk about some emerging literature in the area, and more, how I became interested in this issue in particular. I'm going to talk about a recent study, and this is really just sort of a hot off the press findings from that study. And then I'll wrap up. Maybe I'm going to talk a little bit about some implications, and we'll have time for questions. So in terms of definitions, these definitions actually come from the business literature, if anyone's interested. And there is a reference list at the end of the presentation, and if anyone wants further references, just contact me later. So middle managers are often defined as, employees who are supervised by an organization's top managers, so senior management, and who supervise frontline employees. When I talk about innovation, the definition I'm using is an idea, a technology, a practice, a program, an intervention that an organization is using for the first time. And so that might not be entirely innovative in the sense that other organizations may use it, but it's new here, right? It's something new in this setting. And when I talk about implementation, I'm referring to the period that follows the decision to adopt an innovation, during which targeted organizational members ideally become increasingly skilled, consistent, and committed in their use of an innovation. So this definition, for me anyway, here is important because what I was studying and what I'm interested in really is what happens after the adoption decision takes place. So after people decide to make full use of an innovation as sort of the best course of action available, right, is what they want to do. So after the decision happens. So implementation actually involves behavior change to put an idea into practice. The reason I'm sort of interested, a lot of my work is around implementation, and the reason I often focus on implementation is there's a whole lot of, and I'll be talking about some management literature here today, but there's a whole lot of research in the management and organizational sciences literature that has demonstrated that the poor uptake of innovations is actually, it's often commonly a result of a failure of implementation. It's not intentions, it's not more like it's because things fall down at the implementation level, and we don't realize sort of the benefits of those innovations. So why middle managers? So I want just want to remind people to mute their phones or. So there's someone that's, I think, not on mute. I wonder if you guys could check. Thanks. Sorry about that. So why middle managers? So I want to talk a little bit about why I became interested in middle managers. And I decided to talk about middle managers today just as a backdrop to everyone because I went back through a lot of the last 3 or so years of KT Canada seminars, and I've seen a lot of them, but I also went back through the list and no one had talked about specifically middle managers. And so why am I interested in middle managers? A few years ago I did a study. It was published now a few years ago. And what I was looking at was the implementation and use of synoptic reporting tools in 3 areas of cancer care. I wasn't specifically looking at middle managers. I was looking at sort of what are the common and distinct factors that influence the implementation of these tools. And basically what I found was that middle managers' support or lack of support, it goes both ways, so it's support or lack of support for implementation had a really big impact on implementation itself. So whether they were supportive of and committed to the implementation or whether they weren't. And this is just a table from there, but essentially where middle managers were supportive of implementation, the implementation in those cases or at certain hospital sites, let's say, went incredibly smoother. It was facilitated, it was incredibly smoother, it didn't take as long, and so on and so forth. Whereas where middle managers were not as supportive, it took a lot longer. It was a lot more challenging for everyone involved, I would say, including the implementation teams, but also including frontline staff and so on. It also sort of, there were sort of behaviors that were associated with sort of, the facilitating influence or high support, or sort of an impeding influence or lower support. So for those managers that were supportive of synoptic reporting tools, they did a number of things. One was they explicitly demonstrated their moral support for implementation, and by that they did things like actually inviting frontline staff to come to some of the pre-implementation meetings and the planning meetings, actually asking for input from frontline staff, so showing staff that they supported implementation. The next thing that they did was exert the authority that they had within their departments or their units and so on, around policies, priorities, and resources. So for example, they could free up resources, and this is often staff time. It's not always fiscal, it's staff time to actually dedicate some time to implementation. And the other thing that they did in many of the sites was influence the development of new policy related to the innovation. And so they would be sort of ambassadors or champion the innovation to senior management and to people in the administrative and executive levels of the organization, who then had the authority to sort of enact policy around its use. But they also could have, and did have in some situations, sort of an impeding influence. And in those situations, often, they can choose other priorities, right, within their department and limit sort of resources that are put to implementation. And in some ways, I suppose the best way to put that is just sort of ensure that implementation was something that was sort of carried out off the side of one's desk, right? It was never sort of a priority in the department. And of course, middle managers, like anybody, I mean, they have agency. We all have agency, right? And what we say and our actions sort of can affect others and influence others and what they think and what they do. So I'm going to go back. So being a researcher, this is one of the main findings that came out. And so then I went to the literature as someone who's, a researcher. So I went to the literature to figure out, okay, so what's been done in the literature around this? Like, what do we know about middle managers? Because this was a finding that didn't come from, this was grounded in the data, that's what we would say. So it was inductive, it came up through the data. It was not something we were looking for, and in fact, in the conceptual frameworks, the implementation science sort of framework that was used for this study, middle managers wasn't sort of a core part, wasn't in that, right? So this came out quite strongly, and it was grounded in the data. So I went to the literature. So this is sort of the state of the knowledge, I would say, at the time that these findings were coming out. So it was published in 2014, so like 2012, 2013 or so. And at that point, middle managers, the role of middle managers specifically in implementation in healthcare and in sort of knowledge translation in healthcare had received very little attention in the published literature. And of course, there was a huge focus, and there continues to be a really big focus on the influence of senior leadership, executive level leadership, and frontline clinicians on implementation. And that's despite the fact, I guess, that, you know, middle managers potentially have a big role in the day-to-day activities of how these things happen, how implementation happens. So then I went and looked into the management literature and sort of organizational sciences and business. And there's a whole lot of evidence, perhaps not surprisingly, in that literature and in non-health sectors of the influence of middle managers on implementation and organizational performance. So I'm not going to go through all of this, but I mean, you know, middle managers' commitment to implementation and sort of support of implementation is linked in non-health sectors in the evidence to implementation speed, to realizing an organization's strategy, to productivity, to increase profits, to enhance competitiveness, and so on, right? So there's a big body of literature there. And again, their influence can be positive or negative. And then I stumbled upon, I was searching sort of outside of my realm, outside of the health literature, and I came upon a bunch of work that Floyd and Wooldridge had done, and I'm not going to go into these studies. I've cited some if people are interested in it. But they consider the implementation role of middle managers as sort of the most important role that a middle manager has in terms of organizational performance. And so they view implementation as not solely carrying out what senior management tells you to do, right? It's not just sort of being the person on the ground who does exactly what the senior level are asking you to do. But it's really an adjustment of organizational, so top priorities and directions to sort of emergent issues. So what's happening on the ground, what's happening in my program, and sort of being able to adjust and work through and negotiate the organizational priorities and directions with sort of what's happening on the ground and what's emerging and so on. And so if you think about it, and this comes from thinking about them as boundary spanners, right? So they're able to sort of span both the management of the organization as well as the frontline level. So this is all interesting to me from the perspective that in healthcare, there was none of this, right? There was no recognition of that sort of important role for middle managers. There was some evidence from the NHS in the UK that performance is related to what happens at sort of the mid-level of the organization, again, realizing sort of hospital strategy and so on. And there were a number of studies, and there weren't that many actually, explicitly exploring sort of middle managers' support for implementation in healthcare. I'm going to give a couple of examples here. I'm not going to talk about the studies at all, but you know, here's one from Chang et al. Around 2011, I think, or so. I can get it for you guys. And essentially, they were looking at sort of middle manager support for an innovation. It was for the implementation of work-based learning. But essentially what they found was that middle manager support was highest when managers felt that the innovation fit their workplace needs and priorities, and they had more control over how it was implemented. Here's one in BC that was looking at the implementation of a framework, a public health policy intervention it's called, but it was a framework, a public health sort of policy framework. And essentially this study was exploring the implementation of that framework. And what they saw was that what they found essentially, it wasn't implemented well. And it sort of, the intent and vision of the framework was lost during the implementation process. But if we want to look at the managers themselves, so there are interviews here with middle managers, And there was sort of a low support, that shouldn't say non-support, that's probably a wrong way to put it, but low support. So there was low support for this framework. But when they looked at the reasons for low support, there was a few things that came out. One was the managers had an inadequate understanding of the vision or intent of the framework. I mean, really, you know, a limited understanding of why the framework was being implemented, right, and what the purpose was. Limited involvement in sort of the framework development process, and expected to implement it with few, if any, additional resources, which to them meant this was a low organizational priority. The one thing I did find, and this is the last thing I'll talk about before I get into the study, the one thing that was out there was Sarah Birkin and colleagues in the US had published in 2012 a theory of middle managers, the middle manager's role in implementation. And this was at this point a theory. And so it really, she's done some work since actually, and a number of papers published since trying to test the theory, but this was sort of her and her colleagues' theory around how middle managers sort of support implementation. And it's all around, it's basically all around the fact that they fill the structural position between top management and the frontline people, and so they're able to bridge informational gaps that often impede implementation, that often obstruct implementation. So they're sort of a conduit for information to flow from top to bottom, top to bottom, top to bottom, right? So it's about sort of mitigating informational gaps. And so they say, in this theory anyway, that middle managers express their support for implementation through diffusing information, synthesizing information, mediating between, you know, strategy and the day-to-day activities that are actually required for something to be implemented, and selling implementation. So all of this led to a study to further examine the poorly understood role of middle managers in implementation in healthcare. So this was funded by one of the last CIHR open operating grant programs. And I don't have the team members up here. I should say who the team members were. And so it was a small group of us. There was myself, I was a PI, Ava Grenfeld out of Toronto, and so she is well known in cancer health services, but she's also a KT expert within the cancer world as well. Two clinicians, Jeff Porter and Tony Raymond, who are surgical oncologists and a medical oncologist who work within, obviously, cancer care, and a middle manager, Amy Folks, who was a middle manager in the cancer system at the time, is now a middle manager outside of cancer, but in healthcare as well, in a hospital setting, and Cynthia Kendall, who's a PhD student right now. So we got together, a small group of us, and put in an application that got funded. So the study aims were to explore the role of middle managers in says innovation, adoption, and implementation. That's an error. It is around implementation. And then identify the factors that influence middle managers' support of innovation implementation. It was a qualitative study using grounded theory. The study was in Nova Scotia and New Brunswick, so I really wanted to get outside of Nova Scotia a bit and to see if middle managers in another setting experienced a similar role, experienced implementation in the same way, and whether there were similar factors across settings. And New Brunswick was chosen. New Brunswick, in terms of population and so on, very similar to Nova Scotia, but a few things at the time were different. Now, Nova Scotia has just undergone a major restructuring in our healthcare system, but there were differences in terms of centralization of services, differences certainly in terms of like the ratio of academic clinicians versus community clinicians and so on. So things that might influence implementation. There were semi-structured interviews, and the participants were middle managers in the cancer system in various different places, whether in clinical care, may have been provincial cancer programs, and so on. All related to cancer. It was hinged on cancer, but I actually don't believe the findings are specific to cancer. I think they're applicable outside. So it was propulsive sampling. We wanted to get sort of variation on professional background, so so whether people were clinicians previously or not. We wanted variation in location, so where people are, and that included academic, community, but it also included sort of outpatient, inpatient community-based sort of healthcare settings, delivery settings. Data collection continued until data saturation. So the intent was to continue data collection until data saturation was reached. This was, and so we did concurrently, as you would do in grounded theory, sort of analysis and data collection at the same time. I will say we had a hard time recruiting for this study in one province in particular, and I think there are reasons for that. I think it's because in Nova Scotia, we were undergoing a major restructuring, and it was just not the time to be recruiting middle managers. And I say that to be quite frank, I think that was what was going on there. But nonetheless, there are still Nova Scotia managers here. And we had a big discussion around data saturation, and that's continued actually. And I had a discussion this morning around it again. But 2 people coded the data independently using grounded theory approach, and one of those was the middle manager, and one was another team member. So they coded it all independently, and then I was we're weekly meetings and discussing it and so on. And we actually do think we reached data saturation. I don't think at the end there were no new substantive issues coming out, but I say all that because if you see on the next slide, there were only 17 participants, and we were hoping to get maybe 25 or so, just sort of based on past work and when you reach it. But we had 7 in Nova Scotia and 10 in New Brunswick. 14 had a clinical background and 3 had a non-clinical background. So I don't think we achieved sort of the variation there, but you know what, it was very hard to find non-clinical managers. I don't know if not a lot of them exist within our healthcare. So especially in hospital settings, they sort of had a clinical background. In a clinical care setting, and so I think this is representative actually of reality. Certainly a range of departments and programs and different types of interventions and innovations that have been implemented. It's not up there. There were 4 males and the rest were female. I also think that's reflective of reality, at least in Nova Scotia and New Brunswick. It may not be elsewhere. So the study findings, so I'm going to talk about role first and then sort of the factors that influence support. So it was really interesting to me, again, sort of seeing what's been out there in the literature in healthcare in particular around implementation, and that there was very little. And then these are the findings. So the main overarching finding, I suppose, or thematic finding around role was that middle managers, and these were all middle managers, so this is from their perception, but they are the people who are responsible for making implementation happen. So they are the people that do it. They are the people that have to make sure it happens. They have to make sure it happens whether they support it or not, really, like whether they really think this is what should be happening, right, or not. Like this is their role, or this is their job. And I have a whole list here of sort of activities that came out time and time again in all of these interviews around making it happen. But they do everything from information gathering, navigating sort of processes, like approval processes or vendor processes, contracts, communication, so being the point person, writing memos, creating educational tools, arranging the education and training sessions. That's up to them to, for sort of this new innovation if it's needed and so on. That's up to them. Ensuring that everyone who needs the training actually gets it. Preparing budgets for applications, and requesting additional funds if they need them, a lot of promoting and championing and advocating for it, getting buy-in from the front line, getting buy-in from the top, quality assurance, so all the quality assurance that comes along with the implementation, supporting staff, keeping morale up, which is a big thing. Bringing people together, they're the person organizing the meetings, organizing the committees, organizing the working groups, sitting on the working groups, making sure that all the stakeholders are on the working groups and so on. So by and large, they, from their perception, they are the people that are responsible for making it happen. And we have sort of taken all those activities, and we won't show you here, but essentially synthesize them into these 5 roles: facilitator, organizer, planner, motivator, and evaluator. So the big part up here, I think, is what this is telling us is they're making it happen, but I mean what they're doing is translating the idea, the goals, whatever those are, whether they come from the bottom or the top, into action, right? I want to say this part about recognizing that they're part of a team, and so over and over as well in the interviews, it was we. And so we purposefully asked people, and it was added, you know, you say we, but yet you're doing all these things, right? And so, and they're very purposeful that it's not about I. It really is a team effort. Even though I'm the one responsible, I mean, it's a team effort, right? And it wouldn't happen without everybody. There were, however, two issues, I'm going to say, so two overarching issues that that sort of, they had to negotiate in order to sort of make it happen, right? And that they sort of, that sometimes made it challenging to make it happen. One of those is many roles. So this is really interesting because many of the managers in this study, many of the participants still had clinical duties. So in addition to being managers, they still had some clinical duties. So they would be what we would call hybrid middle managers, still with some professional duties. And of course, they have their managerial duties, which are sort of the ongoing operations of the unit, the program, the service, whatever it is that they're doing. So there's a lot of workload issues, and I think there's an overwhelming feeling of being spread too thin, essentially. And so they're negotiating that along with implementation. And so many of the managers discussed implementation as being sort of something separate, right? It requires additional work. It's not sort of part of the clinical and managerial duties or responsibilities they have, but it's still their responsibility, but it's sort of a third responsibility that's on their plate. And it requires additional work and additional learning. And so I would say that largely in our data, many of the, even if they didn't, well, obviously you saw 14 of them had clinical background, and many people were in manager roles because of that clinical background and because of their credibility in that clinical background, but didn't necessarily have managerial training, right? So a lot of discussion around learning both in terms of their managerial duties but also the implementation duties, and having to do a lot of self-directed learning, and that was just a constant thing that they were doing. In terms of limited decision-making power, it's interesting because, again, they feel as though they have limited sort of authority or power around decisions, around innovations, and whether they're going to be implemented. So top management typically makes sort of the big decisions and set the parameters, right? And so they have to work within those parameters. And so they do have some decision-making power within their units and parameters. So, I mean, you can shift line items in a budget, for example, right? Or sort of shift around staffing, but they're not making the big decisions, and so sometimes that's difficult, again, to make it happen if you're not involved in that and don't have a lot of say. So in terms of study findings around sort of factors that influence their support for implementation. And so I should say, I'm not sure if I said it then, I think I did, but in terms of their role in making it happen, it was clear from I would say nearly all participants that it doesn't really matter, or they don't feel it matters if they support it or not, they still have to make it happen, right? Like that's part of what they have to do, and they have to make it happen. Or if they're, when I say support, you know, if they're fully engaged and fully committed and so on, they still have to make this work. And so I would say the data would show us that there was two sort of overarching issues in terms of supporting and sort of fully engaging in the implementation. The first is how easy will this be? Or, I mean, the flip side is how difficult will this be, right? How challenging will this be? And so there were a few sub-factors or sub-themes that came into this. The first is resources, and I would say this was the most common thing that came up over and over and over. A big chunk of the data is around resources. And so the participants clearly realized that they work in a reality where there are increasing demands that are not met by increased resources. And so demands are increasing constantly, but the resources aren't. And there are many competing interests and priorities. So from the perspective of implementation, this means that not everything that is proposed can be implemented, but not everything that's implemented can be well implemented. It's just not feasible, right, in the current environment. One of the biggest things that came across really in terms of sort of a struggle around resources is around staffing-related cost and training-related cost as an example. So when implementation is happening in your service or your program, you know, they're responsible for getting staff trained and educated and getting the skills and the knowledge that they need for this change. But they're also responsible for making sure at the same time there's no disruption or interruption to that clinical service, right? And that has money implications because Often they may have to send people away to get training. They have to reimburse people if they're doing training outside of their work hours. If they're doing training in the work hours, they need to bring in temporary staff to actually cover, you know, and to make sure there are no interruptions. And so if the implementation is considered that, and the folks, you know, resourcing the implementation is considered that, then they're much more supportive, and they've considered staff-related costs and training in particular. But the participants said, by and large, that's inadequately or insufficiently resourced, and sometimes not at all. It's just something that's completely overlooked. You know, not surprisingly, managers are much more sort of supportive or apt to be sort of fully engaged in an implementation if it fits with their existing environment or it's compatible. And there are 4 particular things that people talked about. Alignment with organizational goals. So again, if something comes from the bottom, I'll say the bottom, but clinical. So if there's an innovation that's being driven from clinicians largely themselves, you know, if it doesn't fit with organizational goals, it's going to be very hard to get the approval and the sign-off from the top, right? So you have to make sure things are sort of fitting with the organizational goals. If it aligns with current clinical practice. So is this project, what we're doing, or is this implementation really just formalizing something we already do, or is it completely brand new, right? And completely brand new things clearly bring up a lot of resistance from people. Or is even things like the physical layout. Does our physical layout actually allow us? Like, how is that? Can we do whatever it is we want? Do we need more space? Do we need more equipment, and so on? If staff already possess the required knowledge and skills, they're much more likely to support the implementation, and I mean that minimizes the requirement for training, right, and education. And again, where the dollar is going to come for that. And compatible with existing IT infrastructure. And then the other part is around buy-in. And so buy-in from frontline staff is critical. And so again, the question is, how easy or hard is that going to be, right, to get that buy-in? Because it's going to be very hard to implement if we don't have buy-in from the front line. Clinician-driven innovations are more likely to have that high staff buy-in than something coming from the outside or from the outside, you know, maybe horizontally or from above. And that's because they believe clinician-driven innovations are more likely to be addressing an actual gap that we have in our program, and more likely to be proposing solutions that will actually work in our program. And of course, if something though is coming from the ground or from clinicians, they need top manager buy-in. So they're selling, right? And how hard is that going to be to get that? And then what benefit? The other question is, what benefit will it have patients? And so there are a number of things here. One is that it was very clear in our data that managers felt a very strong responsibility to ensure patients receive the best possible care. I'm not sure if that's something that's sort of transferable or if that's because many of our managers were clinicians previously as well, right? And it's a reflection of some of that as well. But certainly they did. And so they would, you know, they talked about evidence for benefit, and sometimes evidence comes from explicit sort of scientific sources and so on, or I shouldn't say just explicit evidence or scientific evidence, but oftentimes it doesn't, right? So it could be information from sort of professional organizations or reputable organizations, like the professional association or something like that. Clinical experience, local data. So local data often carries a lot of weight, like local surveys that have been done or local QI data and so on. And then, you know, their peers, networking with peers in other hospitals and jurisdictions, and have they done it? And is there a perceived benefit, right? This is really big. Does the solution address a local gap? So middle managers in this study were much less likely to be supportive of things that they felt, you know, well, that were not novel. So is this really just doing the same thing over and over and over again? Or that do not actually address, they're offering solutions for something when there's no problem in their actual program or service, right? And the example that was brought up was patient satisfaction. That was brought up by many folks. So patient satisfaction is important, but why would we do another thing? Why would we spend all this time trying to put in another project, program, tool to increase patient satisfaction when our local survey data show us that our patient satisfaction is 98%? Like, it's not worth the effort, right? Clinician-driven innovations, much more likely they believe to benefit patients, again, and to benefit their patients because they're actually addressing real gaps that are happening in delivery of care or whatever. And high benefit to patients. If there is a high benefit to patients, that usually equates really high commitment. It doesn't matter about the other things, about the ease, about the resources, about all that. You know, they're willing to be fully engaged if there's going to be a benefit to patients. So I want to talk about implications for a bit. We should have some time for questions. So I would say this study suggests overarchingly, like overall, that middle managers, at least the ones in this study, feel they have a limited involvement in the decision to adopt innovations and in setting those big parameters. They feel they lack skills and training and knowledge around implementation and how to do it and that sort of thing. Yet they're the people, again, you know, expected to facilitate, organize, plan, motivate, and evaluate to make it happen. I do want to point out here, I don't want this to come across as sort of a negative thing. Our middle managers in this study, in general, view implementation very positively. It wasn't viewed as negative. But I think what this shows is that there's a potentially important and strategic role that goes beyond just addressing or bridging informational gaps. So we'll bring up Sarah Birkin's work again. And her theory, right? And this is really around this idea that a middle manager bridges the informational gaps between top management and frontline clinicians. And I actually think they do. I don't think they don't do this. I think they do, but I think they do a lot more than this, is sort of my point. So if I went through my long list of activities, and we sort of mapped out a long list of activities that middle managers say they do in implementation. And, you know, certainly they sort of diffuse information, you know, they purvey information, they sort of synthesize it for people and so on, but they do a lot more than this. And I think that they may be a key link between adoption and implementation. And so this is why I kind of defined adoption earlier as well, right? So adoption is the decision, implementation is the action, right? And so I think they're a key link for translating. They translate the decision into action. Which is very interesting to me in terms of why their role has not been explored in implementation science and KT. And I don't know if it's because a lot of the work in KT, although it's shifting quite a bit, don't get me wrong, but a lot of the work kind of has been around adoption and so on versus sort of the implementation, and so we haven't fully made that link. But so why is it important? So why is this important? Why am I sort of harping on middle managers and their importance and their role and so on? Well, I think it's because, again, just because something's adopted, a decision was made, it does not mean that it actually is implemented, right? And so I love this quote. It comes from the management literature. It's about from the manufacturing sector. It says, when organizations adopt innovations, they do so with high expectations, anticipating improvements in organizational productivity and performance. However, the adoption of an innovation does not ensure its implementation. Adopted policies may never be put into action, and adopted technologies may sit in unopened crates on the factory floor. And I think that probably anyone here who has worked in healthcare can think of an example, a comparable example there, right? So what are some risks of low middle management support? So I bring this up. This data, this is implications. So this is not the data from my study here. This is just thinking about prior work, this work, and then what's out there in the literature. And so I've had people say to me, and I suppose in a way it's playing the devil's advocate in that, well, if middle managers have to do it anyway, they're responsible for making it happen, why does it matter if they support it or not, right? Like, what does that matter if, you know, if they have to do something, they have to do something. Well, I think there's risk of low middle manager support. And so I think it's worth putting this out there. One of them is sort of, you know, this idea of dragging your feet, right? So making things a little more challenging, if they're not fully, if they're not engaged in it and don't see this sort of value, and so dragging their feet, making things a lot longer, you know, and maybe undermining the credibility of implementation. So again, you know, we all have agency in what we say, and our own actions can influence others. Not achieving effective implementation, so things might get implemented, but to me, and this is also comes from a definition in the management literature, effective implementation is the consistent, committed, skilled use of an innovation, right? And so you may not realize that consistent, committed, and skilled use if the managers is not fully engaged, right? Maybe not doing a lot of QA to make sure people are doing this, maybe not providing feedback, maybe not doing a full sort of training and education to the extent it should be, right? So I think that we put a whole lot of effort, everybody puts a whole lot of effort into implementation, and so we want to realize those things. I think we're also maybe endangering the scale up and sustainability of the innovation, whatever it is, and endangering the implementation of future innovations. And so I'm going to go back to the synoptic reporting work that I did, that I started with in the beginning. And so I would say that that work in particular, when there was low manager support, and certainly in some settings there was very high support and things went very smoothly, right? But when there was low support, you saw the drag their feet, you know, the dragging the feet, sort of like just the lengthening of it and so on. And you also saw there was a lot of data that would have suggested that there was not effective implementation. So even though the synoptic reporting tools were implemented, like you could use it, there was not effective implementation of that. There was not consistent, committed, and skilled use of those. So what might be done to support their role? I think there's actually, I mean, I'm sure there's a huge long list. I think there's a few things, though, we can think about. One is at the individual level, and I mean at the middle manager level when we're talking about specific projects and so on, is to involve middle managers early on, as early as possible, so they understand the need for innovation, like the need for that particular sort of innovation, whatever it is. Provide or try to make easier access to sort of external evidence to show the benefit again and why this is coming and what's happened elsewhere. Because oftentimes, I mean, the middle managers in this study talked about having to go out and find that, right? Like they're the ones looking for all of this. And I think there's a role for whether it's formal or informal, sort of formal training, or whether it's sort of mentoring, coaching, and sort of skills development in maybe things like change management, even quality improvement, really, in a way, right? So things that can help them in that role. At the organizational level, I mean, you know, it might sound funny to say, you know, I think top managers need to sort of understand and leverage the strategic role of middle managers. But I mean, there's things that could be done, and one example might be sort of creating networks of middle managers. And this has been done in the management, like non-healthcare sector as well, right, within organizations or with like-minded organizations. So creating these networks around implementation so they can learn from one another. So similar, I suppose, to a community of practice sort of a thing. This is my wrap up here. Since sort of I've taken on this work, and in the last couple of years, there's been, I say, a smattering of recent papers. There's still not very much out there on the role of middle managers. It's quite sparse, in healthcare implementation in particular. Our understanding of the role and experience of middle managers remains remarkably thin. And I have no idea if Katie Dainty is on the line or not, but this is her words from a paper that she's previously or just recently actually published around the role of middle managers in quality improvement, actually, which is not exactly the same, but, you know, very, very similar. And that was sort of her words, that it's remarkably thin. But if we look at, here's a BMJ open systematic review that was published a couple of years ago, and this was just on the role of hospital managers in quality and patient safety. They included 19 articles in this, and only 3 actually included middle managers in those primary studies, only 3 primary studies. The rest is all at the board and executive level. So even in quality and patient safety, which is not what I'm talking about here, right? There's little known about the role of middle managers. So I think this is an area obviously ripe for sort of further sort of conceptual work, actually, but also a lot of empirical research. Like there's a whole lot that can be done here, and there's a whole lot we can learn from management and see if those sort of findings apply in healthcare or not. And that's it. I want to thank CIHR again for funding this study, but not up there, but certainly thank obviously all the participants who took part in this study and the whole team. Now we're open for questions. Yeah. Is it facilitated questions, Andrea? How does it go? Okay.
Yeah, so just wanted to thank you, Robin, for some really important food for thought, and we're going to open it up for some questions, starting with the University of Alberta. Any questions there?
Nope, no questions here, thanks.
Moving on to Winnipeg. Guessing no questions in Winnipeg then. We'll move on to Western.
No questions at Western, thanks.
Okay, McMaster.
No questions at McMaster.
Queens. Moving on to Queens.
No questions for us. Thank you.
OHRI. Okay, I'm going to guess no questions then. Hotel Dieu. Moving right along to Laval. Okay, so we'll throw it to St. Mike's then.
Robin, it's Sharon. So great presentation. Thanks so much. I just had a question around, you mentioned that there's very little kind of in other areas. Have you guys looked at kind of the organizational literature from the community perspective? Because it seems to me that that would be the other kind of area to look at. And in particular, some of the stuff that's been done by Greg Ahrens, for example, looking at kind of the role of the middle managers, and is there potential kind of to learn from that body of literature, do you think, or not?
Yeah, absolutely. So, so I haven't been, most of the stuff that I've been looking at outside would not be community-based. I will admit it's more hospital-based in healthcare or sort of clinic-based. And then in the management literature, I have been doing quite a bit, but I have to say it's also more organizational-based. So I think there's actually quite a bit to be learned from community settings. And I'm aware of some of Greg Ahrens' work in the U.S., and I'm trying to think now if he's been involved in some of the work that Sarah Burton is doing. But it has been largely sort of organizational-based. So I think there actually can be a lot, yeah.
You might be somebody, I don't know what you're planning to do for next steps, and that would be my next question, but as you kind of, if you're kind of focusing in this area for future work, so just as a point of interest, he is looking to collaborate more in Canada. He spends part of his time in Vancouver and part of his time in San Diego. So, so he'd be very interested, if this is potentially of interest to you, I would encourage you to reach out to him.
Okay, yeah, thank you. I know that Sarah Birkin and I have talked about working together. Well, we actually are working together on something completely separate on this in terms of cancer and in terms of survivorship. But we've been sort of trying to work together and sort of formulate some thoughts around this as well.
Great, thanks.
So Winnipeg does have a question. They chatted to me, but I prefer to see if they could ask it themselves.
Can you hear us now?
Yeah.
Okay, hi, thanks very much for that. It's Katie Sibley here at the University of Manitoba. Thank you, I really enjoyed that presentation, and I'm sort of living this experience of working with these types of folks in some of my studies, but have never really broken down that piece of it, so it was really insightful, thank you. My question that we were sort of debating here as you were talking about it was the piece when you were talking about adoption being the decision and implementation being the process. And it's a bit of semantics and hair splitting, but I was sort of saying, oh, is adoption the decision, or is adoption ultimately the outcome? And that, because that's your use, or like that's when you're saying someone does or doesn't do the behavior, or I don't know if you could speak to that a little bit.
Absolutely. So I've done a lot of thinking about this, and when I kind of delineate or demark, like, you know, adoption from, so my first, a couple comments, adoption from implementation. I do so recognizing it is not linear, first of all. And I know that makes it sound very linear, but it's very cyclical, it's very iterative. You know, people may make a decision to adopt something, but only part of an innovation, and then parts are implemented, and then other parts come on, or some people may choose to adopt and other people may choose not to adopt, right? And implementation is going on throughout. So I don't mean to make it sound like linear, first off. But the other thing around, is adoption the outcome or is it the decision? Well, I suppose I do, to try and make it clearer in my own mind, in my own head, and again, I'm an academic, right? So like writing grants and that sort of thing, or a paper, to try and make it clearer. I have tried to figure out what is adoption and what is not, knowing it's all iterative and messy and it doesn't go in a linear way like that. I totally recognize that. But I do go back to sort of I guess the diffusion of innovations in Rogers, and that's how he defines adoption, is that it's a decision. And it's the decision to sort of, again, make use of sort of this innovation as the best course possible. And I do use that because, to me, I try to sort of give a definition around it so I know what I'm speaking about, right? So I'm talking about decision making often when I'm thinking about adoption. Not that decisions aren't made through the whole course. And then I tend to then see, so I don't see it as the outcome unless a decision was made to do it. Like I would see it, the decision might be the outcome, but it's not the use. I would see sort of implementation. I often look at use of a practice or something, and uptake, let's say. Uptake is the word I often use during implementation. And then I would look at post-implementation sustained use or sustained uptake. It is semantics, but I think it makes it a little clearer, particularly when I'm sort of, articulating it and writing it down. I think of the adoption as the decision, which comes from, really, to tell you the truth, it comes from Rogers and diffusion of innovations.
Okay, thanks. So would you then have a third term at the end, or would you roll the use into how you're talking about implementation?
So implementation, so I would say that I often talk about uptake during the implementation period, and then sort of sustained use after, so post-implementation. And I'm doing a study now on sustainability, and so in terms of sustainability, I would look at, so post-implementation is essentially, there's not a good definition around where we should start looking at sustainability, but it's after sort of the initial sort of, after the resources are taken away, those initial sort of push of resources for the implementation, which tends to be how things happen, right? And once that's taken away, so then I call it sustained use, I guess, or uptake post-implementation. I probably use use and uptake. As I'm talking now, I recognize I use use and uptake very, interchangeably. And then I would look at, for sustainability, for example, I wouldn't look just at use. I would look at, if I were measuring sustainability, I would be looking at things in terms of capacity for whether there was increased capacity within the setting, whatever it is, for the use of this tool, the actual use or uptake of the tool, let's say if it was a tool, and then sort of any benefits that have been achieved. Because ultimately what you want are the benefits, right? Like, does use of whatever it is actually, do you get the intended benefits? I don't know, I've rambled a bit there to try and explain how I do it, but for me, it makes it clearer to talk about adoption as a decision that is made, and then sort of implementation, then to be able to look at use in both the implementation period as well as sort of post-implementation, recognizing that it's much messier than that in real life, and there's no demarcation like that, yeah.
Okay, thank you.
Okay.
Hi, it's Gail here. I have a chatted question, which I think is from Hotel de la Vie. What suggestions do you have to support middle managers in the implementation of innovations in the healthcare setting? If the middle managers have given low support to date for a project, what are some key ways to regain their commitment and engagement?
So there's a few things I think I actually am not kidding when I say involve them early on. And so I think the earlier that they can be involved, so some of the work that's out there would suggest that, low support often comes from sort of not understanding why the innovation is being put in the first place. And so if they're involved in early on, they'll get to know why this innovation is coming, what it's about, what some of the evidence is for it. So I think the earlier you can involve middle managers, the better, and then they can start to figure out in their own minds, how's this going to work in my unit? Do we adapt it? Are we able to adapt it to fit, and that sort of thing. So I actually think the early as possible engagement. I also think there are benefits of early engagement that is relevant to middle managers, but beyond, and that is sort of having a bit of a feeling of ownership over it. The earlier you're engaged in something and building it, then you get ownership, you get feelings of ownership, right? And so then that increases their support and commitment. So I think the early on. I think the other thing is actually, I think I don't think middle managers are well supported in terms of sort of going into that role in healthcare. Many people don't have management backgrounds. They have clinical backgrounds. They've been very good clinically, like they're often hired because of their clinical credibility, and they move up, and then they move into positions, and I don't think we support them very well, not only for implementation, but also for like the managerial duties. So I think that as organizations, if we want to really get serious about implementing new, whatever it is, like innovations and that sort of thing, we need to think about how we can help middle managers, who are the people that are making this happen on the ground every day, how we can support them to be better at it. And that does involve whether it's sort of training, formal training in certain areas, or whether it's sort of mentoring and coaching and so on. So I think those are two ways. And so I think about middle managers, I always, I don't want to be negative. I think it's just the reality that they're extremely busy people, and that, but the reality is if they support it, things can go really quickly and really well, right? Like they're great. Like they know they have access like to the knowledge and the expertise and the resources. They have relationships up the chain, down the chain, across, like in other, and they can be huge facilitators to get stuff done. But just like anybody, if they don't support something and they don't see the value, then they can make things go slower, and they can undermine the credibility, just like anybody can, right? If they're respected in that sort of a position.
I have a comment from Shelley, who has written, I would offer that there should be consideration given to involving the middle manager in scheduling deadlines for rollout of innovation, being involved in project timeline planning. Organizational project teams work in isolation and sometimes do not have an appreciation for multiple innovations coming toward the clinical areas at the same time. Also, implementation deadlines may be associated with the end of fiscal year, resulting in large innovations being rolled out within very short time frames. It becomes very difficult for middle manager to offer full support, prioritize, roll out, and operationalize staff resources with competing projects.
Absolutely. So my comment to that is I will go back to some of the synoptic reporting work where I first came interested in this, and when middle managers were involved in what I called at that point sort of pre-implementation, even like planning sort of early on, and we're involved in timelines as well, like setting timelines and so on. Again, things more or less, went according to plan and according to time. When they weren't involved in that, by and large, and they were just expected to do it without being in the planning, things didn't go according to, well, things might have went according to plan, but the timelines extended into years, right? And so I think there's a big bonus in having their expertise at the table to understand how, and that increases buy-in, but also just their expertise to understand how this can actually feasibly be rolled out and what feasible timelines are. So I agree completely.
So in the interest of time, I think we'll keep DAO questions till after we sign off. I just wanted to thank everyone for attending. Friendly reminder to please email your site evaluation forms to Gail, as well as your attendance sheet. And our next session will be March 9th with Cheryl Curry. So looking forward to having everybody sign on for that. Thanks so much and have a great day.
Thanks, bye.
Thank you. Thanks.
Thank you.